Good morning, dear students. How are you all? Okay. Before I start my class, just I will give you a small introduction regarding my topic, so it will be easy for you to understand what the topic I am going to take. Suppose today I am going to travel to Delhi by train. So before I start my journey from my place, I can trace my train by giving my PNR number and train number. So I can understand where my train has been reached, and also I can assess when the train will be arriving at my station. So in the same way, the labor, the fetus is the passenger, and the fetus will be traveling from the uterus to the external world. So in the labor room, there is a particular record from where we can understand where the fetus has been reached and when the labor is going to happen. What may be the record? Okay, very good. That is known as partograph. So today we are going to discuss about partograph and how we are going to use the partograph in the labor room. First we are going to see the definition of partograph. The definition of partograph is, it is a graphical recording of the progress of labor and the salient condition of mother and the fetus. So in this definition, there are two important key points. So in the partograph, we are mainly recording the progress of labor. At the same time, we are recording the condition of the mother and the fetus. This definition is given by WHO. And the second definition, it says, the partograph, it is a composite graphical record of cervical dilatation and descent of the head against the duration of labor in hours. In this definition also it says we are recording the cervical dilatation against the duration of labor in progress. So these are the definitions of partograph. Is it clear for you? Okay. Next we are going to see the history of partograph, how the partograph has come into the clinical practice. In 1954, E.A. Friedman, he is the one who described the partograph first in the clinical practice, that is in 1954. He described there is 3 stages in the cervical dilatation pattern. So these stages are, there is a latent phase is 0 to 3 centimeter, and the acceleration phase is 3 to 8 centimeter, and the deceleration phase is 8 to 10 centimeter. So there are 3 stages in the cervical dilatation pattern. So in this picture also you can see this is the latent phase, then acceleration phase, then the deceleration phase. So during the acceleration phase there is maximum rate of cervical dilatation. This is what E.A. Friedman explained in his partograph. And after that in 1969, Hendrik et al. He said there is some difference in the pattern of cervical dilatation in primigravida mothers and in multigravida mothers, and also he said that there is no deceleration phase at the end of the first stage of labor. So in the previous thing we have seen, he said there is a deceleration phase at the end of the first stage of labor, but Hendrik et al. They explained there is no deceleration phase at the end of the first stage of labor, and also there is some difference in the pattern of cervical dilatation among primary mothers and among the multigravida mothers. And in 1972, Philpott, he explained there is progress of labor and the fetal condition, maternal condition, alert and action line in the partograph. So in his partograph, he included all these 3 aspects. In that the first aspect is the progress of labor, then the fetal and the maternal condition, then alert and action line. And this partograph was used in our labor room till 1994. This was the one previously we were using in our labor room. After that, in 1994, WHO introduced the modified partograph, and this is the partograph we are using nowadays in our labor room, that is a modified partograph. In 1994, WHO introduced the modified partograph, and this is the partograph we are using in the labor room nowadays. And in this picture you can see this partograph we were using previously till 1994 we were using this partograph, and in this partograph you can see there is latent phase, then the active phase. So in this partograph, the partograph which is given by WHO, there is no latent phase. The partograph monitoring will be starting only from the active phase of labor. So the latent phase is not there in the partograph which is given by WHO. Now we can see the principles of WHO partograph. While monitoring the partograph, a nurse or a doctor has to follow certain principles. Those principles are, the first one is the latent phase should not last longer than 8 hours. That is what we were discussing. In the labor, as you all know, in the first stage of labor there is active phase and the latent phase. Latent phase, in this principle it says the latent phase should not last longer than 8 hours. That means there is some abnormality in the latent phase of labor. And the second principle is the active phase of labor commences at 3 centimeters of cervical dilatation. So after latent phase, the active phase will be starting, and this active phase should start when the cervix dilates till 3 centimeter. And the third principle is, during active phase of labor, the rate of cervical dilatation should not be slower than 1 centimeter per hour. So in the active phase, the cervix should dilate more than 1 centimeter per hour. And the fourth principle is, the vaginal examination should be done with utmost care. That is, we should follow all the aseptic principles while we are doing the cervical examination, and the examination should be done only between 4 hours duration. And the last principle is, a lag time of 4 hours between a slowing of labor and the need for intervention is unlikely to compromise the fetus or mother and avoid unnecessary intervention. This principle says we can expect 4 hours of delay in the labor. So even if it is in the active phase or the latent phase, 4 hours delay we can expect, and we should not hurry up. So that may be a normal finding. So these are the principles of partograph. Once more I will explain. The first one is, the latent phase should not last more than 8 hours, and the second one is, active phase of labor will be commences at 3 centimeters of cervical dilatation, and during the active phase of labor the cervical dilatation should be 3 centimeter, and the vaginal examination should be done only in the interval of 4 hours, and we can expect 4 hours of delay in the active phase and the latent phase of labor. Next is the components of partograph. So I told you the partograph, it is a record what we are maintaining in the labor room. So there are mainly 3 components in the partograph. The components are the progress of labor, then the fetal condition and the maternal condition. These are the 3 components of partograph. The first one is progress of labor, the second one is fetal condition, and the third one is the maternal condition. So under progress of labor we have 3 sub-components. They are cervical dilatation, then the descent of the fetal head and the uterine contraction. Cervical dilatation, descent of the fetal head and the uterine contraction. And under fetal condition we have again 3. They are fetal heart rate, liquor, moulding of the fetal skull. And under the maternal condition we have pulse rate, blood pressure, temperature of the mother, then the oxytocin regime, how the oxytocin drip has been infused to the mother, and the drugs and IV fluid what we are administering during the labor process, and also the urine. volume, protein and the presence of acetone. These are the components of partograph. Now we can see one by one in detail. The first one is the progress of labor, how the labor is progressing. So, in the previous slide we have seen in the progress of labor there are three components: uterine contraction, descent of the fetal head and the progress of labor. They are in the first one we can see the cervical dilatation, how the cervix is dilating, that we can assess by seeing the partograph. So, in this picture you can see how is the cervix is getting dilated. In this first picture, this cervix is a normal cervix, here there is no cervical dilatation. And this second picture, the cervix is dilated up to 3 centimeter, and in this one the cervix is dilated up to 6 centimeter, and this last one, this is the full dilatation of the cervix. This is how the cervix is dilating, and this pattern of cervical dilatation will be recorded in the partograph. And in the partograph there is alert line and the action line. These both lines will be helping us to understand how the cervix is dilating or the pattern or the rate of cervical dilatation. So, there are two lines, if you see the partograph you can see there are two lines, alert line and the action line. This alert line that is drawn from 4 to 10 centimeter and it represents the rate of the cervical dilatation. And when we plot the cervical dilatation, if the graph moves right to the alert line, okay, if it moves right to the alert line, it indicates the woman should be transferred to some tertiary care hospital. We should not keep the mother in the nursing homes. The mother should need some other management. So, we can shift the mother to the other tertiary care hospital. That is what alert line it says. Then next line is the action line. Action line, it says it is drawn 4 hours to right of the alert line. After drawing the alert line, action alert line, after 4 hours we can draw the action line, and it is drawn 4 hours, and if the graph move right to the action line, critical assessment need to be done and we should manage the mother immediately. That means the labor is delaying, so we should do some management for arresting the delay. This is what the both line, alert line and action line says. Next is the functions of alert line and action line. These both lines will be helping us to understand whether the labor is progressing normally or whether the labor is delaying. And ideally the graph of cervical dilatation should fall left to the alert line, left to the alert line. If it falls right to the alert line or right to the action line, that means the labor is delaying and the mother needs some immediate intervention. That is the first component of the partograph, that is the cervical dilatation. And the second component is the descent of the fetal head. So, we have studied the fetus should descend or the fetus will be descending down throughout the labor, and here we should plot how the fetus is getting descended or where is the station of the fetal head. And once the cervix is 7 centimeters of cervical dilatation, the fetal head starts descending. That is what it says. For the labor progress, dilatation of the cervix must accompanied by the descent of the fetal head, and it may not take place until the cervix dilates 7 centimeters of the dilatation, and usually it is measured at the level of the ischial spine. And if the fetal head is at the level of the ischial spine, you know where is the ischial spine, and if it is at the level of the ischial spine, we can say that is 0 station. If it is above the ischial spine, that is -1, -2, -3 station. If it is below the ischial spine, that is +1, +2, +3 station. So, when we do the pervaginal examination, we can assess where is the fetal head. If we feel at the level of the ischial spine, that is at 0 station, and if it is above the ischial spine, that is minus station, and if it is below the ischial spine, that is plus station. And the third component is the uterine contraction. So, During the labor there is a uterine contraction and the pattern of the contraction will be recorded in the partograph. So, in this partograph, in normal labor the mother will be getting normal pattern of the uterine contraction, and the uterine contraction we can divide under 3 categories, that is mild contraction, moderate contraction and the severe contraction. These are the 3 pattern of the contraction. So, the observation of the contraction should be made every hour during the latent phase of labor and every half an hour during the active phase of labor. So, I told you the latent phase will be lasting for 8 hours. So, during the latent phase of labor every hourly we should monitor the contraction, and once the mother reaches the active phase, that is after 3 centimeters of the cervical dilatation, we should monitor every half an hourly. And in this picture you can see if the contraction lasts less than 20 seconds, if it is less than 20 seconds, that is mild contraction. If it is 20 to 40 seconds, that is moderate contraction. If it is more than 40 seconds, it is severe contraction, that is mild, moderate and severe contraction. And the contraction we are monitoring for a duration of 10 minutes. For a duration of 10 minutes, we should place our palm over the fundal region. Then we can assess the mother's contraction. The uterus will be hardening, that feel we will be having, and 10 minutes continuously for 10 minutes we should keep our palm over the abdomen and assess the pattern of the contraction. And the contraction is usually monitored for its frequency, then the duration and the intensity. Frequency means how often the mother is getting the contraction. In a duration of 10 minutes, how often the mother is getting contraction, how many times the mother is getting the contraction. Sometime if it is mild contraction, the mother may be getting only 2 times. If it is mild contraction, in case of severe contraction, in a 10 minutes the mother will be getting 4 to 5 contraction, that is frequency. And the second one is duration, how long the mother is getting the contraction, that is the duration of contraction, or how many seconds or minutes the mother is getting the contraction. This I told you, if it is mild contraction that will be less than 20 seconds, and if it is a moderate contraction that is 20 to 40 seconds, and if it is a severe contraction that is more than 40 seconds. That is about the frequency. Then intensity, how severe it is, that is intensity. So, intensity usually we are measuring based on the duration. If it is less than 20, that is mild, and if it is 20 to 40, that is moderate, and if it is more than 40 seconds, it is severe contraction. This is the 3 components we are measuring under the uterine contraction. So, they are mild contraction, moderate contraction and the severe contraction. And the contractions will be, we are monitoring for the frequency, intensity and duration. Okay. So, these are the 3 components which comes under the maternal factors or the progress of labor. They are cervical dilatation, then the descent of the fetal head, then the uterine contraction. Okay. Is it clear for you? Okay. Then next we are going to see the second component which comes under the partograph, that is the fetal condition, the condition of the fetus inside the uterus. And usually the condition of the fetus we are assessing by checking the fetal heart rate. Assessing the fetal heart rate is the best method for assessing the fetal well-being. So, under fetal condition we are checking the fetal heart rate. The first and important thing we should check is the fetal heart rate, and ideally we are assessing or we are checking the fetal heart rate once the contraction goes off. With the contraction, when we check the fetal heart rate, sometime it could be more, sometime it could be less. So, after the contraction goes off, we are supposed to assess the fetal heart rate, and the fetal heart rate we should check for a duration of 1 complete minute. That is the ideal time for assessing the fetal heart rate. For 1 complete minute we should check the fetal heart rate and listen the fetal heart rate once in 30 minutes for 1 minute. In every 30 minutes we should assess the fetal heart rate every 30 minutes, and if we feel if there is any delay or there is any abnormality in the fetal heart rate, every 15 minutes we are supposed to check the fetal heart rate every 15 minutes, and if we find any abnormality in the fetal heart rate for successive measurement of 3 times, we can report to the obstetrician or we can do some management for becoming the normal fetal heart rate. Then the second component is the liquor, that is the amniotic fluid. We are assessing the amniotic fluid. So, amniotic fluid we can assess only after the membrane get ruptured. That is a state of liquor that will be helping us to assess the fetal condition. And sometime we can see there is a thick meconium stained liquor, that is a sign that is the fetus is having the fetal distress. So, under this liquor, when we are doing the assessment, if the membrane is intact, we may not be able to assess the liquor. So, we can denote it as I. Then if the membrane is ruptured and if the liquor is clear, that is C. And if the membrane is ruptured and the meconium stained liquor is visible, then we can denote it as M, and membrane ruptured and the amniotic fluid is absent, we should write it as A. So, these are the letters we are using for denoting the status of the liquor. So, if the membrane is intact, that is I. If the membrane is ruptured and the amniotic fluid is clear, that is C. The membrane is ruptured and the meconium is present, that is M. The membrane is ruptured and if it is absent, that is A. So, these are the letters we can write in the partograph for denoting the liquor. And the third component is the moulding of the fetal skull. Moulding of the fetal skull we can assess by doing the pervaginal examination. When we do the pervaginal examination, we can just assess how is the fetal skull or how is the parietal bones. So, based on that we can assess or we can say moulding has taken place, and these are the things we can assess. If the bones are just touching, the both parietal bones are just touching and we are able to feel the suture easily, then moulding has not taken place. Okay, we can just assess the sutures. When we do the pervaginal examination, then we can write it as 0, and when the both parietal bone touching each other, that is plus, that is moulding has taken place, and if there is overlapping of both parietal bone, that is 2 plus, and there is a severe overlapping, that is 3 plus, and usually that should not overlap, severe overlap should not be there, that can overlap. Okay, so, this is how we can denote the moulding of the fetal skull. So, this is the picture, it shows how there is moulding of the fetal skull we can assess by doing the pervaginal examination. So, these are the 3 things which comes under the fetal condition, that is fetal heart rate, liquor, whether it is clear, whether the membrane is ruptured, and the third one is the moulding of the fetal skull. Then the third component of the partograph is the maternal condition, the maternal physiological condition. Under maternal condition, just we can see the oxytocin regime, how we are administering the oxytocin to the mother during the labor process. So, that we can write it in the partograph, that is how many units we are adding into the IV fluid, then how many drops we are infusing to the mother. So, we can just assess how many drops, whether it is 5 international unit or 2.5 international unit, or whether it is 8 drops, 16 drops. So, whatever it may be, you can write it in the partograph. And the drugs and the IV fluid, any drugs or any IV fluid is given to the mother. Sometime if the membrane is ruptured, we will be administering antibiotics to the mother, or if the mother is so tired, we will be administering some IV fluid to the mother. So, whatever is administering to the mother, that can be IV fluid or any antibiotics, that we can write. There is a particular column in that partograph. And the urine we are assessing for the volume, how much volume of urine is passed by the mother, and also the presence of acetone and the ketone bodies also we can write in the partograph. Then the next maternal condition is the pulse rate, BP and temperature. This is a little important while we are assessing the mother, because this is a physiological parameters of the maternal well-being, and the pulse rate should be checked every half an hourly. Every half an hourly we are supposed to check the maternal pulse rate. The reason is, if the mother is going into dehydration, there can be tachycardia. That is why we are always assessing the pulse rate. And the blood pressure also, blood pressure every 4th hourly we are supposed to check, and if the mother is a hypertensive mother, that is any pre-eclampsia or eclampsia, we should check hourly or whatever is indicated in the chart or whatever is described by the doctor. Then the temperature, that is also ideally every half an hourly we are supposed to check the temperature of the mother, or if there is any hypothermia, then it is indicated by the doctor. So, these are the maternal conditions we should assess. So, there are oxytocin regime you should write, then the IV fluid or any injections the mother is receiving, or the urine, the status of the urine, volume of the urine or acetone ketone body, then the pulse rate, BP and the temperature. So, these are the components of partograph. So, till now we were discussing the components of partograph. Just I can just tell you there are mainly 3 components. They are the maternal condition, fetal condition and the progress of the labor. So, under progress of labor again there are 3 components. They are cervical dilatation, descent of the fetal head and the uterine contraction. Then the fetal conditions are fetal heart rate, moulding of the fetal head, then the liquor, how the liquor is. Then the maternal condition, the maternal regime, antibiotic regime or oxytocin regime, then the pulse rate, blood pressure and the temperature of the mother. These are the main components of the partograph. Now, we should know how we are caring the woman based on the partograph. After monitoring the partograph, we can identify how the labor is progressing. So, based on that, we should provide care to the mother. So, I told you there are alert line and the action line. These are the 2 important lines from where we can identify how the labor is progressing. So, here if there is normal, latent and active phase, normal, latent and active phase. So, the first stage is divided into latent phase and the active phase. So, the latent phase is 8 hours, it should not go more than 8 hours, then the active phase start. If the latent phase and the active phase is normal, what we should do is, do not augment the labor with the oxytocin. So, we need not induce the mother or augment the labor with the oxytocin. No ARM in the latent phase and also ARM at any time in the active phase of labor. Once the mother enters into the active phase of labor, we can do the ARM, that is after 3 centimeters of the cervical dilatation we can rupture the membrane. So, with rupture of membrane there will be production of the prostaglandin. So, this prostaglandin will be helping for the further cervical dilatation and the descent of the fetal head, and the labor will be progressing naturally. So, that is what we can do if the latent phase and the active phase is normal. So, we should not augment the labor will be progressing normally. Then if the line of cervical dilatation comes in between alert and action line, ideally it should be left to the alert line. Sometime it will come in between the alert and action line. If it is in between, what we should do is, if the mother is in the healthcare center or primary healthcare center, we should transfer the mother to the hospital because the cervix is not fully dilated. So, in the hospital they can do ARM and other management of augmentation of labor can be done when we are shifting the mother to the other tertiary care hospital, or if the mother is in the hospital, perform ARM and continue routine observation. When we do the ARM, there will be production of the prostaglandin and it will be helping for the progress of labor. That is what we should do. If the rate of cervical dilatation, of the line of cervical dilatation, it comes in between the alert and the action line. Then sometime the line will come at or beyond the action line. Action line is the second line what we are seeing in the partograph. Sometime it comes at or beyond the action line. that says there should be full medical assessment should be done, that is consider intravenous infusion or bladder catheterization or analgesia. So, I will tell you, if the graph comes after the alert line, that is right to the alert line or beyond the alert line and action line, there is a severe delay in the labor. There is severe delay in the cervical pattern or cervical dilatation. So, what we can do is we will be planning the mother for the cesarean section. That is what it says, intravenous infusion should be started and the bladder should be catheterized, and we can plan for the analgesia. Then sometime we can identify the prolonged latent phase. The latent phase, that is the first phase of labor, the latent phase will be prolonged. In case of prolonged latent phase, medical assessment should be done, and the woman, sometime the woman may not be in labor process. Otherwise, if there is a severe delay in the latent phase, we can plan for the cesarean section. And that is how we can manage the mother in case of the prolonged latent phase of labor. Then the last one is membrane and fetal distress. In the status of the membrane and the fetal distress, if the membrane is intact or ruptured, sometime the membrane must have ruptured 12 hours or more. In that condition, we should administer the antibiotics. Then if we are assessing the fetal distress, we can plan for the operative delivery, and if the mother is in the hospital and if the baby is having the fetal distress, stop the oxytocin, then we can advise the mother to turn left side. That will be helping for relieving the fetal distress, and we can do the vaginal examination in order to identify whether there is any cord prolapse, and adequate hydration also can be given to the mother. This is what we can do in the labor room. If, based on the membrane status, if the membrane is ruptured, if the mother is giving the history of rupturing the membrane, start the antibiotics for preventing the infection to the baby. Then if there is fetal distress, if the mother is in the primary health care center, transfer the mother to the hospital, or if the mother is in the hospital, these are the management we can done. First we can stop the oxytocin, then we can advise or we can ask the mother to turn left side, then identify whether there is any history of cord prolapse, and also adequate hydration can be done. This is how we can manage the mother. And the last point is the uses of partograph. So, till now we have seen what is partograph and what are the components of partograph, and by seeing the partograph, the care how we can provide to the mother, and this is the last part, the uses of partograph, and there are mainly 6 uses of partograph. So, in that the first one is it provide a predictive value of the labor process. So, I told you by seeing the partograph we can predict when the labor is going to happen or how the labor is progressing, whether it is progressing in the normal pattern or whether there is any delay in the labor. And the second one is transfer of information become easy when the labor status changes. That is, all the findings, the maternal condition, fetal condition and the progress of labor will be recorded in a same sheet of paper. So, the transfer of the information will be easy. If you are writing in the long hand, it will be very difficult for us to transfer the information to one health personnel to the other health personnel. And the third one is saves writing time of staff against writing in long hand. If you are writing all these in a long hand, it will be taking our time. Then the fourth is it is of educational values as it indicates the nature of labor. So, the nursing students or the medical students, it will be helping for the educational purpose. Then it gives clear picture of normality and abnormality in the labor. So, I told you there is a like action line and the alert line. So, if when we see the graph in between the alert line or action line, so we can just give a clear picture whether the labor is normally progressing or whether the labor is not progressing normally. The last one is a single sheet of paper gives details or necessary information about the labor. So, when we see the partograph, we can get the idea about the labor, the maternal condition we can assess and also the fetal conditions also we can assess. So, these are the uses of the partograph. So, I can tell you the partograph, it is a very good record, or it is a gold standard for assessing the progress of labor and the maternal condition and the fetal condition, and this is the one we all are practicing in the labor room. As a nursing student, you should all use this partograph in the labor room, so we can just assess how the labor is progressing. So, any doubt for you? Okay, thank you.